Thank you, Madam Chair.
Good morning. Good morning.
The future of fetal medicine is very bright. You saw it for yourself, right? Right. So this topic is a little bit depressing, but we need to talk about it because you are the people. We have to face it. It's a topic which unfortunately is coming to the fore because of our work. We have let me say removed the lead from the boiling pot kind of. Well, since the inception of the FMU, we have been diagnosing a lot of fetal defects after 24 weeks, some which are lethal, some which are very severe. Such that the counseling with the couple, most couples would not see the need to go in that pregnancy, which is associated with severe physical or mental handicap or death. So there comes in the issue of termination of pregnancy. So this is the background. However, with this setting, we have the issues of ethics that still cloud this area, the issues of the legality, the institutional barriers in performing the procedure of termination. So I'm hoping that this presentation should clarify, especially the legal framework of what is it we can do, how can we grow, and promote the structured MDT decision-making in trying to help these clients who come to us. So the current reality is that there is delays due to lack of knowledge of the Termination Act and also inconsistent institutional approvals. It's easier in some institutions and super difficult in some institutions. And there's also emotional distress for couples and also staff, especially if couples have made the decision to say, look, this baby will be too much for us, but the approval doesn't come for the termination to happen. So it's like in hell, right? So these defects, when you look at them, they are all lethal or severe defects, but we do encounter them, as you will see from our work, that we encounter all these defects. We've encountered them before. So couples come to us and we sometimes diagnose these kind of defects. And these are some of the couples that we'll be dealing with, besides other severe defects that need extensive surgery for the baby to be okay. So this is our cohort. When we looked at the data of 265 defects, we noted that only 1% of the defects were actually diagnosed in first trimester. The rest, this is public sector data, the public sector data, and almost 99% of the women with defects, they come to us in second or third trimester. So this is the background of the story. And out of them, when you 69% we didn't offer termination because it was not indicated. For the ones we offer termination, the remainder, which is 31%, 8 refused and 24 accepted termination. To just show you the acceptance rate. So our acceptance rate is probably more than 70% for those who need it. So do not think that couples do not accept termination of pregnancy. They do accept termination. Real people, they do accept termination. And these are the defects that we pick in the systems. You can see there from the same cohort that the majority of defects are within the cardiovascular and the central nervous system. If we zero in onto the cardiovascular, you see conditions such as anencephaly are top on the list, and the holoprosencephaly contributes quite significantly. I've mentioned these two because these two, there's no one who moves around the world with an absent brain. This is a lethal condition. And no woman should be asked to say, go all the way to 40 weeks, then we deliver you then. The same thing with the aloba holoprosencephaly. It is a lethal defect. Even semiloba, it is lethal and cause severe defect to those babies who are born. So these are some of the defects that we do encounter, and we try to offer this couple this process, and we have challenges. Then on the cardiovascular, you can see hypoplastic left hearts are there, the heterotaxis. The other ones are probably mild there. They can be corrected with surgery. So these are some of the defects that we are experiencing in real life in the hospitals that we work in. So whenever patients come with defects, what do? From diagnosis, they are cancelled. After being cancelled, if the defect is bad, we have fetal medicine counselors at our 2 units now, a team of counselors who are now dedicated to counseling the patients that we diagnose. They're the same counselors I have told you that we've been working with them for the last 3 to 4 years now, training them in fetal medicine language and terms and the meaning and the natural history of some of these conditions so that they can do they can counsel with the knowledge of the condition. So they are counseled extensively. If they are agreeable to the termination, first of all, they are given clinical counseling by us clinicians. Then we send them to these professional counselors who counsel them a second time. If they do agree, then we start the process of certification. Certification, that means we have to all agree with other members of the team I will show you just now to say, yes, this is a condition that warrants termination of pregnancy. Then once the certification is done, the paperwork is done, is sent to the administrators. In our situation, is the clinical directors to approve, to say they agree with us that we can go ahead and do the procedure. Then bereavement support is offered, then feticide is done, then the induction of labor takes place. The induction of labor is done by the obstetric team. So these are the guys who certify, who agree with us. We, fetal medicine, we will sign our part. The obstetric team will sign. Now we have a sheet where if the condition is surgical, the pediatric surgical team signs. If it is a neurosurgical condition, the same, orthopedic, the same. They do sign, and the neonatologists also sign and agree with us. And our fetal medicine counselor will attach their counseling report on the condition. Then this is forwarded to the clinical director, who then gives us a go-ahead, or she will say no, or the clinical director will request additional information, which we have to supply. Sometimes she denies it, which is reasonable. Right, so then the question is, where do we get all this from? How do we arrive where we are? First of all, we are leveraging on the Termination of Pregnancy Act of 1977, which is its latest update of 2004. This document is available online. You can download it and read it. Then most of the processes of how we came up with our structural process, because there's no national guideline for this, termination of pregnancy for fetal abnormalities, we adopted from this guideline from the COG, termination of pregnancy for fetal abnormality. So this is where we adopt most of our work, and we also use the SASOG here, the position statement on the same subject, which is what the Termination of Pregnancy Act says, the Zimbabwean one. It says we can terminate on legal grounds a pregnancy when there's a risk to the woman's life or physical health, or a severe fetal anomaly, or a pregnancy due to unlawful intercourse. So this is what the law says. Of course, there are holes in the law, and because the definition of this is always the subject of the doctors who are seeing the patient. Then these are the conditions for us to proceed. 2 doctors who are independent should certify that they agree to that decision, and then the superintendent's permission. That's where our clinical directors are coming in. If we are at a central or provincial hospital, the same applies. Then this should be done in a designated institution. According to this law, these are public hospitals. Then the records and reports should be submitted to the Secretary of Health according to this amended law here. So let's compare it to others. So what do others say? Others from other countries, you can see South Africa. If you look here, these are the acts they have in other countries for this purpose. Then the gestational age limit, ours doesn't specify the gestational age limit. It doesn't. Then the South African, they say once it is above 20 weeks, you need special approval. Then the UK one say above 24 weeks, offer feticide first. Then the Australia one, you offer feticide from 20 weeks. Then the feticide protocol is not defined in Zimbabwe yet. We are the ones who are supposed to define it. Then it's recommended in South Africa. It is standard in these other countries. Then the counseling in Zimbabwe, because there is no structured counseling yet, but we are putting the structure. So let's say it's ad hoc for now, because I don't think the structure we've put exists in other institutions. Then in South Africa, there is already a multidisciplinary platform that addresses these issues, and it is standardized in other countries mentioned there. So, what is this feticide? Feticide was simply saying the baby shouldn't be born alive, because being born alive means the baby is subjected to the law that says any baby who is born alive has to receive all the care that every baby deserves. So once the couple have made the decision that they don't want the baby to be born alive, this is where feticide comes in. Feticide is a procedure whereby we will put the needle. I'm not going to play all of it. I just want to show you the needle, because the last time I played it, colleagues were not happy with me. So you can see the needle is going all the way into the baby's heart. So we inject KCl, potassium chloride, in the baby's heart. We titrate because it varies with the baby's gestational age. Small babies will need less, bigger babies will need more to achieve asystole. Once asystole is achieved, that's the end of the procedure. It's done from 21 plus 6. While we have ignored the 21 plus 6, I'll show you why it is to be done from 21 plus 6. This procedure, I'll just show you the complications are very minimal, really. We have not experienced any complications ourselves in our work. So this is why it is to be done. You can look from this UK registry here that before 21 weeks, for babies who are spontaneously delivered preterm between 21 and 26 weeks, you can see that no baby survived before 21 weeks. But after, you can see the survival. This is why once a baby is above 21 weeks, a feticide procedure is to be considered, because some of these babies may live, though the numbers are small, but the chance is there that the baby may live. So to just show you our experience just of feticide, we did this audit in a 3-month period where we looked at 16 feticide that we had recommended, and 11 were successfully done. That means we managed to go through that care pathway we showed you. Then the others were not done because the care pathway got some hitches in between. Sometimes we don't get the signatures. Some people refuse to sign the signature. They say, I can't sign. And some people will say, what about if the baby is born alive? There are all sorts of responses we get from this. So as a result, the delays are done until these women get either into labor or the pregnancies are too advanced to continue. Then one didn't present. So let's analyze the ones who unfortunately were not offered the procedure. So what is of note is that 2 of them ended up having cesareans. The reason for the cesareans is because sometimes the baby will be too large. In this case, we'll be talking of severe hydrocephalus babies. So the babies were too big, the heads were too big to pass transvaginally. Some may ask, what is the benefit of feticide? Whenever we do feticide on these babies, we also do cephalocentesis. Cephalocentesis, that means we deflate the head by aspirating most of the cerebrospinal fluid from the baby's head to make the baby's head small and fit. So they'll end up having a seizure, and 2 delivered NVD, 3 died immediately after birth, and 1 lived beyond 24 hours. But this one is a very sad story to tell, because our counselors followed and interviewed there. I'm not sure Dr. Kasongo may be privy to the eventual outcome, but the baby was waiting. The baby had myelomeningocele with hydrocephalus. So the baby was waiting and waiting in NICU, in NICO, I think almost a month down the line, waiting for potential surgery. So these are the challenges that we have noted over time, that sometimes stigma and religious sensitivity impedes the execution of this service, and some limited counseling capacity. Right now, we just have few counselors, whom I think sometimes they are overwhelmed with the amount of work they have to do and the amount of time they have to commit to counsel all the patients adequately. Then we have the issue of legal ambiguity and delays in approval, then the knowledge gaps sometimes among clinicians and administrators, especially on fetal conditions. Well, sometimes you say the baby has got achondrogenesis, but people begin to ask and say, is dwarfism a problem? But achondrogenesis is a leader form of dwarfism. It's only achondroplasia which is compatible with life. That's what we see when we interact with people. We have a condition referred to as dwarfism. So the lack of knowledge sometimes delays the papers because people will ask questions and say, so is dwarfism a problem? Why are we terminating babies with dwarfism? But achondroplasia is a leader form of dwarfism. The same with thanatophoric dysplasia is a leader form of dwarfism. So sometimes this hambers. I think this is why we are so happy that all registrars are rotating through fetal medicine units now, so that they familiarize with this leader condition, so that in the future, it will be easy for them to understand what's going on. So these are our opportunities. The opportunities we have now is to craft a protocol, for a national protocol that guides what we should do, so that there's smooth if offering of service there. Then we also need to continue educating all the clinicians who work with us on the various conditions and also these procedures. This is why we are here. That is one of the reasons for this presentation. Then we also need to reinforce our MDT. We already have an MDT that we work with, but we also want to integrate this into the curriculum. I think we are already in the process. All the not all of them, but the registrars under University of Zimbabwe are now mandated to go through fetal medicine counseling, fetal medicine rotation. So this is our call to action. Let us build an evidence-based, ethical, and compassionate national pathway for termination of pregnancy in cases of severe fetal anomaly. Thank you.
Thank you very much, Dr.